Welcome, and thanks for attending our session, Medicare Documentation and Legal Issues. Your speakers today are Mark Reagan and Barbara Phillips of Hooper, Lundy, and Bookman, joined by Rhonda Anderson, RHIA QCP with AHIIS Consulting.
Hello, everybody. It's Mark Reagan. This is a program entitled Documentation Still Matters for Medicare Despite COVID-19. Today, I'll be joined by Rhonda Anderson, who's the president of Anderson Health Information Systems, as well as Barbara Phillips, a consultant for that organization. Next, please. So this is a general education offering. This is a required disclaimer. None of us have conflicts of interest that are required to be disclosed. Next slide. Okay, the purpose of this program is to really focus on the notion of Medicare coverage, particularly Part A coverage, under the 1135 waiver issued by the United States government in the spring of this year, arising from COVID. We are going to cover the documentation impacts associated with that particular waiver, which covered both 3-day stays as well as extensions of the benefit period, address the legal and reimbursement challenges associated with it, ensure that you have a sense of the underlying coding requirements to be able to demonstrate accurate coding and the necessary supportive documentation. And last but not least, the need to monitor, track, and trend your particular documentation. Next slide. Also, we'll be talking about the telehealth benefit that has been altered in a very dramatic way through the CMS waiver process that has enabled skilled nursing facilities and other long-term care providers to be able to use telehealth more effectively, regardless of whether they're in a rural or urban HPSA.
We've had a lot of new developments related to the waivers and documentation requirements that have been shifting. Noridian recently came out with the system of edits that went live on October 4th that I think will be really helpful for the facilities to guide them to ensure that they are not submitting claims that are either certain to be denied or likely to be denied, problematic in some way. The system will allow the providers to go on and review the errors in real time that are coming up from the claims edits for things like lack of medical necessity. The claim is coming up as an edit for non-covered services, miscoding, or some sort of the documentation, clinical monitoring edits, etc. This will give you a clear notification of what the problem is, but also how to fix the error, which will guide you in future decisions on not repeating the same error and not getting your claim denied. Next slide. It's going to save time for both Noridian and the facilities. It's very time consuming when you have claims denied for the wrong code, for example. This will allow you to fix it in real time prior to Noridian actually processing your claim. And it's going to improve the transparency of the claim editing system, which sometimes seems mysterious. Why was my claim denied? You're going to get not only why your claim is possibly being denied, but it's also going to show you some of the process of how that decision was reached and give you guidance on how to correct that if possible. Next slide. Ongoing, though, we have the CCI edits. This has been in place since 1996. The difference is that every single year these edits are updated. So what was passing last year may not pass this year because you've got, for example, an invalid ICD code, which has an additional digit. It seems minor, but it will kick the code out of the system, and you might get either a bundling or a denial or of a procedure or service because you've come up in the claim edits, which is just an automatic kick out of the system. So this system is really going to assist you in preventing that type of error.
So one of the first things that happened after the public health emergency associated with COVID-19 was declared by the Secretary of HHS was that the CMS and Secretary Azar of HHS issued an 1135-1812F waiver, which focused primarily on the 3-day qualifying hospital stay and the waiver of the benefit period associated with Part A coverage and skilled nursing coverage under the Medicare Part A program. Ultimately, those two were folded into what was described as a blanket waiver associated with all forms of different operational requirements associated with the timing of submissions of various documents, transfer discharge, room changes, and the like. It was a very comprehensive blanket waiver that was issued by the federal government, but it began with this 1812 waiver. The 1812F waiver is an existing statutory provision under United States law that allows the 3-day stay and the benefit period to be extended under emergency circumstances by virtue of the impact of those emergencies on particular beneficiaries of the program. The expansion of telehealth access came through the blanket waiver, which followed the 1812F waiver that I just spoke about. That was designed, obviously, to be able to ensure that beneficiaries, wherever they may be, will be able to get access to primary and specialist care services without having to travel to particular locations to receive that care and treatment, placing them at conceivable risk of COVID infection, and likewise to allow for physicians and other professionals that would need to provide care and treatment to them. And to the extent that it could be provided in a remote virtual way, then those individuals would not enter, in our world, long-term healthcare facilities and therefore not present the risk of exposure to themselves as well as to residents and staff. Next slide, please. So one of the most significant and really one of the driving forces behind the program we're doing today was the 1812F waiver that released the 3-day qualifying hospital stay requirement for Part A skilled coverage in skilled nursing facilities. It was described to be temporary in nature. It was designed really around 3 fundamental principles. One was to make sure that there was sufficient inventory of acute hospital beds, such that if there were patients in acute care hospitals that would require skilled nursing post-acute care, that they could be moved out of an acute hospital before a 3-day period of time that would otherwise qualify under the 3-day stay requirement. The second set of circumstances would be that if there were residents or people who became residents or essentially people in the community or presented at an ER, then rather than placing them in a place where they would be subject to infection as well as not be able to deal with the significant issues that they were experiencing, then they could also be served in a skilled nursing facility under Part A coverage, assuming that they qualified for skilled services. And last but not least, patients that were already in facilities in a long stay, typically, situation, to the extent that they had a change of condition or an emergent condition that would have required them to go to an acute care hospital, that the 3-day stay would be waived for that particular purpose, so they did not present a risk of exposure to themselves, risk of exposure to others, and again, that there was all efforts being done to preserve inventory of acute care hospital beds. All of this being said, it is unclear to us today how CMS, how the MACs, and how the various alphabet soup of contractors will actually apply the fundamental principles associated with a 3-day stay waiver that has now been in place for almost 7 months, and something that is likely to continue through the public health emergency through January of next year. We know by virtue of direct communications with representatives from CMS, John Kane in particular, that there will be review and scrutiny of these particular claims. And so one of the fundamental purposes of what we're talking about today is, how is it that you get paid for these services, and how is it that you retain your particular payments and make sure that you have the necessary and appropriate documentation in place to be able to ensure that you keep those particular dollars that you earn. Next slide.
Some examples leading up to the scaling of a resident for a 3-day qualifying stay. As Mark mentioned, of course, you have your new admissions that are coming from an acute care hospital or an ED sometimes, or those that are skilled in place. In the facilities, we've come across a number of situations where it's very confusing whether or not the resident is going to qualify. One example would be a resident who perhaps was in the hospital for COVID-19 and has recovered from COVID, or they have a history of COVID-19 diagnosis. They are currently not COVID positive, and they're transferred from the hospital into the facility. They may qualify if they have some conditions. This is one that's very iffy as far as qualifying for coverage. If you have a resident who's tested positive, you're likely going to get coverage at least through the 14-day observation period and perhaps beyond, or those with or without symptoms who have a positive test. Those with a history, however, may still get coverage. An example would be someone who has post-intensive care syndrome. That's something where a resident has been on a ventilator because of COVID-19 and has respiratory issues lingering on account of that long time being on a ventilator. That would have to be very clearly documented in the medical record for you to be able to cover this resident under those conditions. There is a diagnosis of PICS, post-intensive care syndrome, which you would code. And also we'll get into some of the other coding issues. Another one is where the resident has been in the hospital, has had a serious decline in ADLs, and really is in no condition to go home. Again, you would have to really have a diagnosis, something that you would be able to use to skill this resident for needing rehab. We're going to use the same for those who don't have an active COVID diagnosis. The waiver, the 3-day qualifying stay, you really need to go back to the basics. Whatever was in Chapter 8 of your Medicare benefit manual is what you're relying on. We're not having any new rules. They have not changed any of the rules for that. The real confusion has come in for people where they're skilling people for COVID in particular, whether that be for the 3-day qualifying stay from the ED or if they develop COVID in your facility. Another part of this would be where the resident is exposed. We have had residents in the facility where a staff member becomes positive. There are no residents in the facility that are positive. However, there's a possible exposure. Unless there is a real need to skill that resident where they are highly at risk due to comorbidities, and you are doing very constant monitoring of that person because their condition is likely to change, you would be at risk skilling that resident just for being a person under investigation or possible exposure. We'll go over more of that in the coding session coming later in this presentation. Next slide.
The waiver of the benefit period is the second significant waiver that was issued in March of 2020, along with the 3-day qualifying stay. The waiver of the benefit period relates to the notion of the 100-day Part A skilled nursing benefit, along with that 60-day interim period before a new benefit period can start. What HHS did with this particular waiver was to say, look, for beneficiaries who have been delayed or prevented by the public health emergency for beginning or finishing the process of completing their benefit period to be able to sort of, in our world, attain or maintain their highest practicable physical and psychosocial functioning, that they would be able to continue with their Part A SNF coverage to be able to ensure that they reach their highest practicable outcome. Recognize, however, that there is a direct linkage of the extension of the benefit period to some element of prevention or delay caused by the public health emergency. So it is important from a documentation standpoint, as Barbara will address shortly, that that there was impact from the public health emergency on the course of treatment and the episode of care experienced by the individual beneficiary that would justify this particular extension. Next slide.
So getting into some of the examples of when someone may or may not qualify for this waiver. The one that was given on the slide here directly came from the waiver itself, where they were warning you that, for example, if you have a continued need, for example, you've got a long-term care resident who has had a feeding tube. They've already been skilled for this. They've been in the long-term care for quite some time, and they are continuing on as normal, no change in their condition. It would be very risky to skill this resident for this, under the waiver for this feeding tube. They've already exhausted their 100 days coverage for this, and they're not likely to get another one just for the continuing need. This is one we have seen a lot of problems in the facilities, where a resident, for example, has a condition like chronic obstructive pulmonary disease. People are skilling for a diagnosis that was identified 2 years ago, has been continuing, has had no exacerbation of symptoms. This is not going to qualify under the waiver benefit period as a new condition. You really need to clearly document that there has been some sort of exacerbation of that COPD, for example, that would qualify this resident, where you would normally have sent them out to the acute care, but you're going to skill them in place without the 60-day period of wellness. Another one that we're seeing under the skilling in place is examples where residents have had decline in ADL functions in the past. They've perhaps had a course of therapy. They've exhausted their benefits or gone off had their last covered day. And the facility is looking at their condition. There's been no decline in function. There's been no documentation that the resident's ADLs have changed. Perhaps they've been with an RNA and receiving services for the RNA and remain stable. And the facility decides to skill them for therapy under the waiver and give them a new benefit period. This again would be a very risky use of that particular waiver. You need to show that there is some emergent condition that has happened, some change in the resident's condition that has happened that would qualify them for a new benefit period, as Mark has very clearly stated in the guidelines directly from the regulations. So there is some confusion there. The other one comes again when we get back to COVID and the new benefit period. If someone is exposed, for example, to COVID, they're asymptomatic, there's nothing going on with their vital signs, you're probably not going to be able to give them a new benefit period for suspected exposure or exposure to COVID-19. However, you may be able to qualify for a new benefit period if the resident becomes symptomatic in place. The waiver benefit period in the 100 days and the 3-day qualifying stay overlap somewhat, especially in these conditions where you're looking at a resident who perhaps has extended they have their 100 days already, they don't have their new wellness period, and you're not wanting to send them to the hospital. So again, you're not doing the 3-day qualifying stay where you'd normally send them out, but you do have a condition that you're going to give them a new waiver, a new benefit period, because that they have now developed COVID in your facility. So there's some overlap of those two waivers, the 3-day qualifying stay and the new benefit period, but they're all very highly contingent on the resident having a skillable condition that is one that was always the same guidelines that we've used in Chapter 8 of the Medicare Claims Benefit Manual. At the end of the waiver, they very clearly stated when residents are skilled or tested positive for COVID, but they're asymptomatic, you really need to also be looking for comorbidities. What comorbidities would put this resident at risk where you would have to have skilled or therapy level staff reviewing and documenting on this particular resident for the observation of symptoms. So the key elements there are really the skilled observation of symptoms by your licensed or therapy staff. And again, those are the same requirements we've always had. It just becomes a little bit muddy because we've got the ability to skill them in place. Next slide. We've just given you some examples here. Medlar Matters, and the link is attached to the slide here, is an excellent resource for clarifying some of the muddy waters that we've had to navigate through during this COVID emergency. Next. On the documentation end of things, you're going to want to be able to identify those residents where the waivers had applied, whether it be a waiver of 3-day benefit period or they've been given a new benefits period. This is important for a monitoring standpoint. You're going to want to be able to, in later days, be able to, for example, let's say that you get an advanced document review from your MAC and you've got to provide documents. You're going to want to know who are these residents who we've used these waivers on. You're going to want to make sure that the documentation is clearly presented when you are defending your decisions, and that includes all the documentation related to what would justify the use of this waiver. So knowing who these people are in advance is going to help you from a monitoring standpoint, and also as well as ongoing when you're able to pull the claims and look at the impact on your facility. The triple check process needs to be very robust right now. And I see this being applied very hit or miss in the facilities, but you really need to be looking now at that you're using the proper claims codes, that you're identifying the resident was skilled under what type of a waiver, whether it be for the 3-day qualifying or the new benefit period. And Mark's going to go over that soon. Next. What tools do you have in place to guide your staff to getting that documentation? You really need to assist your staff in providing the support to your claim. Have you enhanced the skilled monitoring for charting of symptoms, for example? The monitoring of vital signs and O2 stats and COVID symptoms in particular. Most of the facilities have done some sort of changes to their documentation where they have got care plans that are very specific to the COVID symptoms. They have got the monitoring of vital signs and O2 stats in various locations. You're at a very good disadvantage if you have a EHR where you can provide reports on either as per shift basis. You can, for people who are going outside the parameters of, for example, their temperature, their O2 sats, which are critical in really the skilled monitoring of those symptoms of COVID-19. Also use of things like revised respiratory assessments to assist the staff in giving very detailed information about the observation of the resident's respiratory status, which is one of the key indicators and problems related to COVID-19. Also, Do you have performance measures in place so that you have qualitative review of documentation and coding? That's getting back to, can you identify and pull out who is under a waiver so that you can very clearly make sure that those residents' charts are prioritized for a qualitative review of that documentation and that the coding is accurate. And then again, the QAPI for infection control focus, that is one of the new requirements under the surveys, the infection control survey, and you really want to be showing that you're on top of it as a facility, that you've used these performance measures. We're continually self-identifying where we have issues, where documentation might not be as good as we would like it to be, or we're not having the outcomes we want to see, and that this has been kicked up to the next level. Next slide. Again, it needs to be a data-driven process. So you need to show where your performance measures are being documented, they're being presented into your QAPI committees and also your quality assurance process. And this also supports your compliance program, another of the new phase 3 requirements for CMS. Next. Medicare certs and recerts completed timely. No change. There's no waiver. So facilities have had to really deal with when the physician is not coming into the facility like they normally do for their initial visit for Medicare A or doing their monthly visits. They're all being done remotely. What system do you have in place for getting your Medicare cert, which is supposed to be done within the first 72 hours, unless it was done in the hospital and by the same doctor, and then your 14-day cert, and then going on to your updates for your 30 days after that? We don't have any kind of a waiver for that. We have to have these certs completed timely. They do need to support the condition for which the resident is being skilled. You can use a delayed cert process when necessary, which most facilities have something in place that would identify right on the cert itself why the cert was not done exactly on time. Maybe it was due to COVID. However, most of the facilities are doing a workaround in this where they're either faxing or presenting in person to the office of the physicians these certs so they can get completed on a timely basis. So the certs, again, are absolutely critical, have got to be in place, have got to be completed timely, or there's got to be a documented reason why not. And then as soon as possible completed, and also to support whatever documentation that you are skilling that resident for. Next. There was a waiver for the delivery of the NOM-NOC and the advanced beneficiary notice, which is supposed to be presented in person to either the resident or resident representative. This allowed that the waiver could be delivered via telephone, FaceTime, email, or another method that allows the resident, if you're doing it for the resident, to ask questions. The whole point of the face-to-face is when you're telling the resident that their benefits are ending, that the resident can ask you questions and give them the right to appeal if they don't agree with your ending the coverage. You can do a telephone or a secure email to a beneficiary representatives who are off-site. And all of this, I'll tell you on the next slide, please, needs to be annotated on the particular notice. We all have a written notice where we are providing this to the resident or resident representative. And when you're doing it using this alternate method, you would annotate how, when, and to whom the notice was provided, and if it was an email, where it was sent, if applicable. You might be thinking, well, why would I even use this alternate method? Well, normally that's to keep your staff safe. If you've got a resident who's active COVID in your facility, is housed in the COVID unit, you want as few people as possible going into that particular unit and face-to-face with that resident, putting the other person at risk. So this alternate method gives you a way of providing that without actually exposing your staff to additional risk. Next.
So We have not changed the terms and conditions of Chapter 8 of the Medicare Benefits Manual and the underlying statutes and regulations by virtue of the 3-day stay waiver and the benefit period waiver. There still must be the requirement, well, there still is the requirement that skilled care is demonstrated, that these services are ordered by a physician, that they be for a qualified condition, that skilled services are required every day. Next slide. That they can only be provided on an inpatient basis at the SNF. That obviously doesn't relate to the notion about whether they could have been provided at an acute care hospital, but could be safely performed at a SNF, that they are reasonable and necessary services, that physicians must certify and recertify the need for skilled care, and that the underlying documentation along the lines that has been addressed be sufficient in nature. Next slide. So on the billing side, you would follow the same rules that you normally do with a couple of tweaks with respect to the PDPM system. A 5-day MDS, there is no interrupted stay policy applying in these contexts. You follow all of the existing PDPM rules, and you include the HIPS code from the 5-day MDS and use the DR condition code, or I believe the CR condition code if we're talking about Part B. Next slide. These are some specifics in terms of detail about how to bill patient status, when to complete the 5-day MDS with respect to extensions of the benefit period beyond the 100 days, and then again to use the HIPS code from the new 5-day assessment, and to readmit the beneficiary from a billing standpoint to start the benefit period waiver timeframe. Next slide. And with respect to the various component elements, particularly the variable per diem elements of PDPM, they begin from that first day. Again, the condition code used is DR. A condition code for readmission, as previously stated, is used 57. And then in the remarks section, to be able to enter COVID 100, identifying that we're going beyond that 100-day period without the 60-day wellness period. Next slide. So it's really important that you do a good job here in terms of documentation. We know from John Kane and others that there will be audits of these claims. It's really important because you do not want to lose this revenue, particularly when we have the CARES Act and other elements of support that is going to calculate our lost revenue. And so it's really important that we do as good a job as possible to understand when we can claim Part A coverage without a 3-day stay and when we can go beyond that 100-day period. And we have to really focus on that particular daily documentation of care. We need to make sure that we don't lose the physician's cert timeframes associated with the notion of the disruption caused by being able to preclude visitors, and thus the importance of the ensuing telehealth waiver that we'll talk about, and ultimately the relationships between a qualifying stay being waived and the extension of a benefit period and COVID-19. Next slide.
Coding is going to be very important, as it has been in the past, in justifying your coverage for PDPM especially, but also just in identifying the different types of residents that you have skilled for coverage. The U07.1 is one that was added mid-year in April, actually, and this has been a historic change. The ICD-10 codes never are updated other than annually in October, but they updated this code, U07.1, for active COVID diagnosis in April. So you can tell how important this was that we capture these and we capture them accurately. The other codes, the C codes for encounter for observation for people that are suspected are not going to map as a clinical primary diagnosis. And nor is the suspected exposure to other viral communicable diseases. None of those 2 Z codes, or even the one with their history of COVID, there's actually no history of COVID code. We have to use a very generic history of communicable disease. And you want those to be able to support what types of residents you're observing. For example, the resident who is skilled for person under investigation or suspected, you're going to give them that Z03818. But for PDPM, you do not have a principal diagnosis that is going to map. You cannot use that diagnosis for your PDPM principal. You're going to have some other diagnosis that is skillable to qualify under one of the clinical categories for PDPM. So this is a kind of a technical issue and a complication, but it's a very important one. Next slide. So COVID-19 accurately coded and sequenced. Of course, it's going to be your principal diagnosis in almost every case where you're coding for that U07.1. But as I said, let's say you have someone who is one of the suspected, you've got a Z code, you may have a high-risk diagnosis that may also be coded as their principal diagnosis. You've got a Z code for their COVID where they're suspected, but you've got a high-risk diagnosis as their principal condition. That post-intensive care syndrome, cognition dysfunction, or other mental health problem because of depression, those could possibly be your principal diagnosis code. But the diagnosis has to be accurately coded, and it really must match your test results. And those test results need to be in the electronic health record or the manual record. The issue that most of us have run into is that because of the dire need to get those test results back within 48 hours, many have 2 systems of labs doing their lab results for the facility, one for COVID and another for all their other types of diagnostic conditions. And sometimes and now we have also the testing machines that are being used in the facilities to give an almost immediate result. Those results must be found in the medical record to support whatever it is, the diagnosis that you're claiming, especially if it's someone that you have, said is active COVID. And even the negative COVID is important because that is what's going to move them through the system of being person under investigation back into the green zone, so we say, of those residents who are not at risk for COVID or not, actively exposed to COVID or COVID positive. So getting those test results into the charts in a timely manner in whatever method, even if it's mixed, it might be something that it's appearing in your EHR and your lab talks to your EHR, or it might be a paper document coming in, or it might be something where you're doing an on-site testing. Those all have to find their way into the medical record. Next. Again, you need to obtain the test results from the hospital if they're transferring you a COVID positive resident. Verbal is okay. We're not required to get a lab result from the hospital saying that they're transferring us a COVID positive resident. However, it really is the best practice to obtain that lab if necessary. Of course, the facilities are always testing everybody. When they come into the facility, they're a person under investigation immediately when they're coming in from the outside. You're going to want to code that diagnosis, get that on the medical diagnosis list that works its way through the system, ends up on your EHR or on your diagnosis list in the facility, which ultimately ends up being what you code and report on your billing claim. Next. Ongoing communication regarding your infection status for residents who are either exposed or become positive to COVID is critical. For those being skilled in place or given a new benefit period, you're going to want to pick those codes up immediately and get those into your system so that they are going to accurately and be sequenced. For example, your U07 COVID code is going to probably be sequenced, well, most likely be sequenced first as your principal diagnosis when you're doing that new MDS 5-day for a resident being skilled in place, or even a resident coming back in from the facility, or when they're COVID positive in your building, you need that communication. Also, the personal history of infectious disease, which I told you, the Z8719. The only reason that's really important is, for example, the example I gave you earlier about where a resident is transferred from an acute care hospital. They had COVID in the past. You know now the COVID, if you've had COVID, it's documented. You don't necessarily retest or don't retest for 90 days. You've got a resident in your building now that has a history of COVID, and there's no code for that except this Z8619, and you're putting that person under investigation, or however you're putting them in place in your building. You're going to want to be able to document this in your record, and this is kind of a placeholder code that you would be able to know that anyone Z8619, when you run at the end of the year your list of codes, was a person that was in this category. They had a history of COVID. The documentation in the record and the testing results are going to need to support how we reacted to this particular resident who came in or with a history of COVID. Next. The facilities that are treating specific COVID-related syndromes, something like post-intensive care syndrome is a new diagnosis. We need to be picking those up and sensitive to looking for those. Our trauma-informed care screening due to critical illness is our screening process in place for the trauma. Are we care planning? All the possibilities of either infection for COVID, the psychosocial needs related to COVID, how it impacted your residents' activity participation, and depression, which factors into your quality measures. So that documentation is nothing new to us. We've done this for PDPM ongoing. So it needs to be strengthened, though, to support your documentation if you're dealing with residents related to COVID-19. Next. You're going to want to leverage your RAI process. Any forensic nurse will tell you the first thing they go for when they're reviewing documentation for some sort of a claim problem or even a court case is that MDS. So what's identified on the MDS, the accurate coding of your isolation process, as we all know on the RAI, the isolation process, isolation cannot be coded unless the resident is in a room alone. Cohorting with other residents, 3 other COVID positives, does not qualify. So your documentation in your RAI needs to start off the process, and it needs to be substantiated and justified throughout to be paid appropriately under PDPM, and also to justify in your quality measures that you're achieving your outcomes. Next. Track your documentation, your modifications. We've had many guidances from CMS, from the AFLs, and there's been documentation changes in place due to these ongoing shift in focus, how we test, when we test, etc. So you need to be able to track those processes. Next. Have your system in place where you have your temporary documentation that relates only to the COVID-19 documentation changes. So it's going to be reviewing anything of system impact related to documentation. It's going to start retroactive March 1st. It's going to go through the public health emergency, and it's going to cover things like telehealth. It's going to cover things like how you skilled under the waiver and how that was documented in your medical record. All of these very important. They're fresh in your mind now. They're not going to be fresh in your mind in 2 years when you have an ADR. So, or even when you have a survey, you're going to need to be able to pull, this was the system in place at that time, beginning and ending on certain dates. Next. Examples of documentation challenges have been the monitoring of vital signs critical to observations, your daily skilled or change of condition and Q-ship charting, and any comorbidities that put the resident at high risk. All of this documentation has got to be in place, And it does have serious legal or reimbursement implications if it is not done per your mitigation plan and also per the CDC guidelines. Next. Admission for a change condition, you're going to want to look for increase in falls, altered mental status, dehydration, etc. These are related risks that may actually put the resident able to go either into a Medicare A skilled stay if they weren't already, and do the 3-day waiver or a new benefit period. But the documentation of these symptoms related to COVID is critical. Next.
So we're moving to telehealth. I spoke about one of the most significant aspects of the waiver was the lifting of the rural versus urban distinction, which that lifting basically allowed for all practitioners as well as those facilities within urban environments, HPSAs, to be able to take advantage of those circumstances that only rural facilities have and rural practitioners have been able to do under the previous telehealth statutory and regulatory structure. There remains, however, a resident consent requirement in California that can be verbal but needs to be documented. Also, that there was an announcement that while there wouldn't be a waiver of HIPAA compliance, in fact, there would be more flexibility on enforcement. And that was really about being in a position to use platforms like FaceTime and Zoom that may not have some of the same types of encryption protection that you would expect to be HIPAA compliant. Next slide. So there was this temporary public health emergency policy for telehealth adopted. Telehealth visits being done in lieu of physician face-to-face visits, as well as not only physician extenders like physicians, nurse practitioners, and physician assistants, but also for those residents who are capable of using virtual technology, some use of physical therapy, occupational therapy, and speech language pathology. Not appropriate, certainly in all instances, and not something that we would expect to see continued after the public health emergency ends. What we are hopeful for is that after the public health emergency is over, that we will be able to demonstrate to policymakers that in fact the use of telehealth across all geographies, whether they be urban or rural, will in fact enhance the quality of care, actually produce more efficiency, and not have excess expenditure, which has always been the concern from CMS in terms of utilizing a more restrictive telehealth policy than has been in place during the public health emergency. Next slide.
The clinical record documentation related to the telehealth is certainly another aspect that we continually want to look at. Looking at the progress notes, and does it clearly state that the visit was provided via telehealth? As Mark has mentioned earlier, the consent and the provision of services for the telehealth per your facility policy. And so this is an area that we know will be important in terms of both documentation, in terms of legal, and in terms of the residents' rights. Next slide. One of our challenges, along with the many others that have been described today related to the COVID waivers, one of the challenges has been to get the signature of the telephone orders, the certs, and the monthly orders. That's not totally new to us. However, if you're going to have an audit or have a review, and if I've noticed recently that the OIG has been conducting a number of telehealth reviews and waiver reviews for the acute hospital or outpatient mostly, but if it's going to that division or that area, it's certainly going to come to us too. So the telehealth visits made by the psychiatrist, by the psychologist, the therapist, as they explained earlier, making sure that we have the documentation, and that it's been provided based on the need of the individual. And is the ID team aware of any of the changes after the telehealth visit, the communication following the visits, and any new diagnoses identified after the visit being recorded? Next.
One of the things that I wanted to follow up with Rhonda is that in talking with providers about the use of telehealth, one of the things that they find particularly advantageous is you have the care team present during a physician encounter that may not be the case under normal circumstances. However, they found that experience obviously to be more time consuming, especially if the physician's appearance on a virtual basis maybe isn't as timely as might otherwise be the case. So we wanted to wrap up this program by first thanking you for attending. It has been an amazing experience so far, and one that I know for many of you has been a heartbreaking experience going through the COVID-19 pandemic. It has been amazing from the standpoint of the willingness of, in this instance, the United States government to waive key provisions to facilitate care and treatment under the Part A benefit for skilled nursing beneficiaries, but also recognize that at the end of the day, there's going to be an insistence on having the underlying documentation to support the skilled services. We want to help you however we can between Rhonda's organization and mine, how to be able to navigate through what may be a difficult process with folks who may not have the same understandings that we all had as we went into the public health emergency, and based upon communications between CMS and ourselves and our trade associations such as the American Healthcare Association, it's important to recognize, number one, the rules haven't changed in terms of documentation, even though the underlying challenges for that particular documentation have clearly changed. I guess other than turning it over to Barbara or Rhonda for final comments, I would encourage everybody to submit questions and those will be provided to us, and we can provide responses after we get together and review them all. So thank you.